Ideally, initial blood loss should be electrolyte solutions to eliminate unnecessary risks associated with blood transfusion. The anesthesia provider, along with members of the surgical team, may need to make a decision as to when the risk of anemia is associated with blood loss supersedes the risks associated with blood transfusion. There is no magic number at which point blood replacement should begin. This decision needs to be made on each individual patient's clinical picture. As hemoglobin levels of 7 grams per deciliter, the cardiac output will begin to increase in order to maintain normal oxygen delivery. Varash states that according to research, the majority of healthy patients will have a transfusion threshold somewhere in the vicinity of a hemoglobin of 7 to 10 grams per deciliter, and patients with a normal hematocrit will be able to tolerate a blood loss of approximately 10 to 20% of their starting volume. In order to calculate allowable blood loss, you must know the patient's estimated blood volume, which is calculated as 75 milliliters per kilogram for males and 60 per kilogram for females. Allowable blood loss is calculated by subtracting the estimated blood volume from the estimated blood volume times the minimum hematocrit. This number is multiplied by 3 to give you an estimate of the allowable blood loss to reach your minimal or transfusion threshold hematocrit. This will cause the transfusion threshold to be decreased. These conditions include any condition that will increase the body's oxygen demand, including but not limited to hyperthermia, sepsis, pregnancy, and hypothyroidism. Any condition that limits the ability for the body to increase cardiac output, including myocardial infarction and coronary artery disease. Occlusive vascular disease, impaired oxygenation, hemorrhage, and abnormal hemoglobin, such as sickle cell, will all decrease the transfusion threshold as well. Fresh frozen plasma should be given to treat clotting factor deficiencies such as DIC or any microvascular bleeding associated with PTTs 1.5 times normal. Fresh frozen plasma can also be used to quickly reverse warfarin therapy and to treat heparin resistance. It can also be used to correct specific factor deficiencies which are not available alone, such as factor V. The indications for replacement of platelets include maintenance of normal platelet level during DIC or ongoing bleeding, prophylactically for patients with thrombocytopenia prior to surgical procedures or any other invasive procedure. Cryoprecipitate should be administered when there is microvascular bleeding in the presence of a disproportionate decrease in fibrinogen, such as DIC. When bleeding due to uremia is not responsive to DDAVP. Prophylactically for patients with hemophilia A, von Willebrand's disease prior to surgery, and to patients with factor 13 deficiency. After the administration of blood products, lab values should reflect the replacement of vascular fluid. Normally, the administration of 1 unit of PRBCs will increase the hemoglobin by 1 gram per deciliter and the hematocrit by 2 to 3%. If a 10 milliliter per kilogram infusion strategy is used, the hemoglobin will increase by roughly 3 grams per deciliter and the hematocrit will increase by approximately 10%. Fresh frozen plasma will increase the level of each of its clotting factors by 2 to 3%. A pooled unit of platelets will increase the platelet count by 5 to 10,000, while an apheresis unit of platelet can increase the platelet count by 30 to 60,000. A unit of cryoprecipitate can increase a patient's fibrinogen level by 5 to 7 times. Prior to the administration of blood products, each donor unit must be tested for compatibility with the recipient. There are 3 tests that a unit of blood product will undergo prior to administration. The first is an ABO test to determine which antigens are present on the red blood cells. This is important because most people develop antibodies towards their non-present antigens. Type A blood has A antigens and most likely B antibodies. Type B blood has B antigen and type A antibodies. Type AB blood has A and B antigens and no antibodies. Type O blood has no antigens and both A and B antibodies. Next, the donor blood is tested for D antigens. Blood with D antigens is considered to be Rh positive. People with Rh negative blood have D antibodies. Antibody screening, or the Coombs test, is done to test for approximately 30 non-D antibodies. It is done by mixing the serum with red cells with known antigens. If agglutination is present, then specific antibodies are present as well. Antibody screening is done on all donated blood and is sometimes done instead of a cross-match. A cross-match tests for ABO and Rh compatibility between the donor and the recipient blood. A cross-match is usually sufficient enough to ensure that a transfusion reaction will not occur. The cross-match mimics a transfusion by mixing the donor and recipient blood products and incubating for 10 to 15 minutes at 37 degrees Celsius and checking for compatibility. The cross-match will confirm ABO and Rh compatibility as well as detect if there are antibodies present. Determining ABO and Rh status alone is sufficient to predict a 99.8% chance of compatibility between donor and recipient. The addition of antibody testing only further increases the probability of compatibility. However, patients with a history of antibody reaction or patients who have had a history of transfusion, pregnancy should always have a cross-match prior to the administration of any blood products. A type-in screen only tests the recipient's blood. A type-in screen is frequently done preoperatively for procedures in which the need for transfusion is low. The ABO and Rh and the presence of antibodies is determined. If the antibody screening is negative, there is a 1 in 50,000 chance that there will be a hemolytic reaction. If there are any antibodies present, the blood bank will identify a selection of potentially compatible units. As stated on a previous slide, type A blood has A antigen and B antibodies. Type B blood has B antigen and A antibodies. Type AB blood has A and B antigens and no antibodies. Type O blood has no antigens and A and B antibodies. Blood with D antigens is considered to be Rh positive. People with Rh negative blood have D antibodies. Displayed is a chart showing the compatibility of blood types. Recipients can only receive blood that does not contain antigens for which they possess antibodies to. For example, A positive blood can only accept blood from non-B antigen containing blood groups, such as A positive, A negative, and O negative. Because A negative blood contains D antibodies, recipients are unable to accept any Rh positive blood. Because O negative blood contains no antigens, it can be given to anyone and is known as the universal donor. Likewise, AB positive blood has all antigens and no antibodies. It can receive all types of blood and is known as the universal recipient. In order to know which product to be administered, it is important for the anesthesia provider to know what type of product each contains. Platelets contain only platelets. Platelets contain ABO antigens, and ABO compatibility is preferred but not required. Rh positive transfusion to Rh negative females of childbearing age should be avoided. FFP comes from the separation of whole blood by centrifuge, and FFP contains all plasma proteins and most clotting factors, including factors 5, factor 8, which decline during storage. FFP must be ABO and Rh compatible. Cryoprecipitate is what remains when FFP is slowly thawed at 4 degrees Celsius. It contains concentrated levels of factor 8, factor 13, von Willebrand factor, and fibrinogen. ABO compatibility is not necessary for cryoprecipitate. Packed red blood cells are collected from whole blood. Whole blood is collected in bags containing a citrate preservative in order to cleave calcium present in the blood. The blood is then centrifuged in order to separate the blood into different components. CDPA preserved blood has a hematocrit of 70 to 75% and 50 to 70 milliliters of residual plasma. The total volume is between 250 and 275 milliliters and has a shelf life of 35 days. CPD preserved blood has a hematocrit of approximately 60% and has 10 to 15 milliliters of residual plasma. The volume of CPD blood is 250 to 350 milliliters and has a shelf life of 42 days. It is thought that CPD blood is able to more rapidly regenerate to 3-DPG. PRBCs can be frozen and stored indefinitely, however preservative must be added and then removed after thawing. Thawed red blood cells must be administered within 24 hours of thawing. Platelets are one component that is separated from whole blood during centrifuge. Apheresis platelets come from a single donor and have a volume of 200 to 400 mLs. Apheresis platelets contain the same amount of platelets that could be collected from 6 to 8 whole blood donations. Platelets must be stored at 22 degrees Celsius and are susceptible to bacterial growth. Because of this fact, platelets are only viable for 5 days. Fresh frozen plasma, another component separated by centrifuge from whole blood, is immediately frozen in order to preserve factors 5 and factor 8. Each unit of FFP is approximately 200 to 500 mLs. Thawed plasma is obtained from thawed FFP that is maintained at 6 degrees Celsius for a maximum of 5 days. While it is immediately available, it does have decreased levels of factor 5 and factor 8. Because of this fact, it is not advisable to give thawed plasma to those who have factor deficiencies, DIC, or neonates. Cryoprecipitate is the precipitate that remains when FFP is slowly thawed at 4 degrees Celsius. It contains concentrated levels of factor 8, 13, von Willebrand factor, and fibrinogen. Most bags contain 5 to 7 units. Cryoprecipitate is stored at negative 20 degrees Celsius and thawed immediately before use. These are my references, and thank you for listening to my presentation.